Welcome back to Stop Feeling Like Shit, and I'm your host, Daniela Korth, with Dr. Buzz, my favorite person. And on today's show, we have our bonus episode, Q&A, and our special guest, once again, Joe Matovich. You're all familiar with his face, and Tiffany Schneid. Hi, everybody.
Hi.
Hi. All right. I would ask how you're doing, but let's jump right into it because I'm busy.
All right.
Let's go.
Pressure's on.
For younger male patients, they're asking why is my testosterone low?
Okay.
Joe.
All right. So 2 causes of low testosterone, primary and secondary. Primary is generally older patient population. That means that there's dysfunction at the Leydig cells that make testosterone. For younger men, that is generally not the case. Secondary dysfunction, essentially what we're referencing is disruption in the communication loop. So the testicles they're producers, right? But they don't dictate their own function. They only work when they're told to work. What tells them to work is the hypothalamus and the pituitary. Hypothalamus makes GnRH. That tells the pituitary to make LH and FSH. That tells the testicles make testosterone and sperm. And that big loop of communication runs on what's called negative feedback, which essentially what that infers is they're going to keep telling the testicles to work until something tells them they don't need to anymore. That something, generally speaking, should be a nice, adequate level, a healthy level of testosterone. So secondary dysfunction infers that the problem is not with the function of the testicles itself, but somewhere on the line, there's dysfunctional communication or an inadequate response from the hypothalamus and pituitary to their testosterone levels, right? Now, what can cause that can be a myriad of issues. We see a lot of patients. We see a lot of patients with history of head trauma. The hypothalamus and pituitary are pretty delicate structures. They stack right on top of each other. They've got an intricate system of vessels and nerves that run between them, and they sit in a little bony structure called the sella turcica in the skull, right, which is not too far back from between the eyebrows. So someone like myself, for example, that has had a baker's dozens of concussions playing sports in their years, you spend most of your adolescent, teenage years, and early 20s banging your head into hard stuff, generally doesn't boast well for endocrine function. Just like we talked about on a previous podcast, we see a lot of adrenal dysfunction or HPA axis dysfunction where because of people working shift work or not sleeping well or having unmanaged sleep apnea or something like that, not that anybody would ever do such a thing, that disrupt their sleep quality, right? That can be causality for it. Of course, other things we can see endocrine disruptive environmental toxins or drugs, but ultimately it's low testosterone, not because the testicles aren't intact or functional, but because there is a break in the communication loop where these glands are no longer regulating testosterone output appropriately. And that's most of what we see in young men.
Okay.
Next question.
Yeah.
When I start HRT, how long will it take for me to feel better? That's still you.
Okay. So I always tell patients there's a short and long-term response. 2 things have to happen. First thing is your level has to improve. And with testosterone delivery or HRT delivery, accumulation of a level happens relatively quickly as long as dosing is consistent. But one of the things we know too is that hormones do communicate through receptors at the cell. And if you have low hormone values, especially for an extended period of time, we'll see that receptor density and function declines. Right? Quite frankly, you're not using them. Mm-hmm. Receptor uptake function and response does improve over time, but it's a little bit of a slower acclimation. So a lot of patients may notice some some mild subjective changes relatively quickly, 2 to 4 weeks. But we always tell patients, realistically speaking, you may be looking 3, 4, 6 months until we see full therapeutic response from how you feel and the long-term metabolic benefits. And of course, within there, there's also going to be reassessment and individualized dose titration and adjustment. So it's, I always analogy it to walking upstairs. It's a little better, but it's not an overnight process. It doesn't take forever either, but it's not like when somebody's like, "Oh, I did my first shot last week and I already can tell a difference." Well, you can probably
placebo a bit.
You probably tell a difference because you took a shot.
I would say most people 6 to 8 weeks to even notice anything, right? And then as you said, I think it progressively gets better.
Yeah.
Unless you just absolutely feel like complete dog shit.
Yeah.
And then something really
something is better than nothing.
Yeah, exactly.
Yeah.
Because I've been there before where I'm like, you know what? I just did this injection, but I feel awesome.
Yeah.
Yeah. So, I mean, I will say I'm one of those people.
Yeah. But full therapeutic response definitely is a building.
Takes a minute. Yeah. All right.
Do I have adrenal disease if my cortisol values are off?
No. So,
And next question.
yeah, so we talk about this a lot, and there's when we talk about adrenal disease again, and this is kind of like the gonads. The term adrenal disease or adrenal failure or things like that, I think gets thrown around a lot. The inference with that statement is that there is something functionally wrong with the adrenal glands or they themselves don't work. Generally speaking, that is not the case, right? So just like we talked about, the testicles are regulated by the hypothalamus and pituitary, so are the adrenals. So is the thyroid for that matter. But essentially what we see, the communicator of feedback with the hypothalamus and pituitary for the adrenals is stress. So a lot of times what we see with patients is your adrenal glands are probably functionally fine. There's a break in the HPA axis in that communication loop where the HPA axis has been overburdened with too much stress for a long time. Where we're seeing significant misregulation of the output of cortisol or from the adrenal medulla, the output of epinephrine and norepinephrine because of long-term acclimation to stress. That doesn't mean the adrenal glands themselves are diseased. It's misregulation that's causing adrenal dysfunction, Now, can you have Addison's disease? For sure. Can you have Cushing syndrome? For sure. And people say, when their cortisol is low, or borderline low, or it's kind of flatlined. Do I have Addison's disease? No. Well, how do you know? Well, you're here. You can't live without adrenal glands. So if your adrenal glands were actually failed or didn't work, you wouldn't be sitting. You'd be somewhere other than here. So there is adrenal disease, yes. In a functional medicine perspective, in the patients we see, is that their adrenal glands are broken or diseased? No, it's negative changes to the entire HP axis function that's creating the negative changes in cortisol output.
Correct.
All right.
What's the difference between bioidentical hormones and what an OB or primary would do?
Yeah, I guess either of us could take this. So,
Go
I'm
ahead.
the question asker,
Okay.
okay?
So all the term bioidentical means is that the hormone itself that we're using is molecularly identical to the hormones the body would have produced prior to menopause or onset of hypogonadism. So one of the things you can't patent anything pre-existing in nature, right? So a pharma company, you couldn't patent just the estradiol molecule or just the testosterone molecule or just the progesterone molecule. So when you look at like a birth control, for example, it's a hormone drug.
Sure.
Most birth controls are norethindrone and ethinyl estradiol. Okay. Well, the human body makes progesterone, estrone, estradiol, estriol, and then has some metabolites thereafter. Doesn't make norethindrone. They're hormones because they interact with the same hormone receptors at the cells, but they are not the same hormone and they don't always necessarily metabolically behave the same. So when we say bioidentical, it means everything we're using is molecularly identical to human hormones, and we're also going to do a physiologic replacement, which means we're going to give you all the hormones you need, just not some of them, right? So, for example, a female patient post-menopause who's had a hysterectomy. Standard of care says she needs estrogen-only replacement. Well, why? Because the indication for progesterone after menopause is endometrial protection. Therefore, if there is no endometrium, we'll only treat estrogen because estrogen is what causes a lot of what people think of like the hallmark menopause symptoms, hot flashes and night sweats and things like that. From our perspective, though, we know obviously progesterone does a myriad of things beyond just protecting the endometrium. So we're going to put that on board and testosterone and correct the adrenals if needed. So,
yeah.
All right.
Is an AI bad for you? Let's start with what AI is.
Okay. So AIs are aromatase inhibitors. Okay. The aromatase enzyme, men and women have it. It's talked about more for men, but essentially what the aromatase enzyme does is it's going to convert a percentage of our testosterone into estrogen. For men, that's where 95% of our estrogen comes from, right? Aromatase inhibitors in their original development were used as a post-cancer intervention for women that had estrogen receptor positive breast cancer. If somebody has estrogen receptor positive breast cancer, the goal is essentially to take their estrogen to undetectable levels to prevent the likelihood of recurrence. Okay. In a male HRT setting, aromatase inhibitors are used as a mechanism to control excess aromatization or excess estrogen creation when you're giving somebody exogenous testosterone.
Which is considered off-label.
Yeah, it's off-label use. And I always like to clarify, because people look at it as a cancer drug. You give me chemo or something. No, it's not. It blocks that conversion. Now, AIs recently have come under a lot of heat right? Because if you look at the negative consequences of AIs, they say, bone density lost and reduced vascular function and things like that. What people need to understand is when you look at publication of drug literature, it's published based on the on-label use of those drugs. So aromatase inhibitors on label are used in an oncology setting with the intention of complete estrogen suppression. And if you have no estrogen, you will have reduced vascular function. You're going to have reduced cognitive function. You're going to have compromised bone density. That's true for men or women. In an off-label setting, like we would use them for men, it's a very minimal dose, not to suppress estrogen, right? To keep it at a therapeutic threshold where you're not causing somebody to be overly burdened with excessive amounts of estrogen, right? So the negative mechanisms of the aromatase inhibitors that are published are really mechanisms of complete estrogen suppression. There's nothing about the mechanism of the drug itself that's going to induce that side effect unless it's something that's overused where you're tanking estrogen to nothing, which from a replacement standpoint is obviously never our goal. So, and to give you an idea of a dose equivalent, you look at a drug like Aromatase, right? That's what's called a suicide inhibitor because it has long-term suppressive mechanisms even after cessation of the drug. Normal dose is 25 milligrams a day. Or Arimidex or an anastrozole. Normal dose in cancer setting is 1 milligram a day. For some of our male patients, they may use 0.2 milligrams a week or 0.3 milligrams a week, right? So we're not doing a suppressive dose. Now, there are some patients, a fair amount of patients, we don't use them with at all because it's not necessary, and that's why care is individualized. And there's a lot of things that will influence that natural genetic propensity. A lot of it is body morphology. I'll be honest, I don't mean to sound crass. If we have a guy who comes in to start care and he's 40% body fat, he's probably going to be a heavy aromatizer, not only from adipocytes as it being a primary location for aromatization, but also estrogen storage, right? And essentially what those aromatase inhibitors do is they bind to the heme ion of the aromatase enzyme so that testosterone can't. So essentially you've got the aromatase enzyme, here's testosterone going for it. The AI is going to give you competition, right? So then less of the testosterone aromatizes.
That's why it's really dangerous for people that self-medicate to not do frequent blood testing and take these AIs because it can be deadly.
Right. And you see, and it's going away a little bit, but we've all seen, even as close as a year or two ago, and pendulums always swing to the extreme side, one or the other. 3 years ago, estrogen was a bad word for men. If I tell somebody, oh, you need estrogen, they're like, I don't want any of that, right? Well, that's not necessarily true. And now the pendulum kind of swings the other way of like, I need all the estrogen I can possibly have, and aromatase inhibitors are terrible for me, and they're going to do all these things, right? So it's weird.
It's a balancing act because you need some estrogen for osteoblastic activity, for ligament health, for libido.
Right. So it is weird that you see the pendulum swing always between one extreme and the other, and the truth almost always lies somewhere right in the middle, right? Yeah. But you're right. People that are self-medicating, especially when you look at the fitness community, and I use this example all the time when you look at like bodybuilding, for example. If somebody goes to the end of show prep, what do they want? They want to be dry and they want to be lean. Mm-hmm. So generally they're actually reducing testosterone dosing. They're using other agents that don't aromatize, and they're pushing estrogen blockers really heavy, taking their estrogen to nothing so they can be dry and lean, and then a week out from a show, they blow a pec tendon or something.
Well, you see a lot of these bodybuilders right before shows have, cardiovascular events, big muscle tears, all these injuries.
Right.
They're crashing the estrogen out.
Yep. So are they dangerous? Are they bad for you? Only when used the wrong way, which is why you have a doctor manage your care and don't play street pharmaceutical technician with your own labs.
Bro science.
Yeah. Bro science, the art of bro science. Yeah.
Leads right into the next one. What is the difference between using SARMS and doing hormone replacement?
Okay. So the term SARM stands for selective androgen receptor modulator, okay, which is really a play on the term SERM, selective estrogen receptor modulator, which is a drug class with like raloxifene and tamoxifen and things like that. The inference with that drug is that they're going to substantially agonize the androgen receptor at the cell, okay? I will tell you what we see them do on paper, okay? When you look at testosterone, we generally talk about total testosterone. A lot of people talk about here all the time, I want my test at 1,000. Okay. Well, the number they're referencing is what's called total testosterone. Okay. Total testosterone is it's a nice, pretty value on paper, but clinically it's not real significant because we know that testosterone is going to go a number of different avenues. Some of it's going to aromatize to estrogen. Some of it's going to get bound in the blood by different carrier proteins, most notably sex hormone binding globulin, that once attached to the hormone, eliminate its capability to interact with receptors of the cell. What's left is your free testosterone, which then will be, 5-alpha DHT or 5-beta androstenediol or any myriad of weaker and stronger metabolites. But that free pathway is ultimately what's available to the tissue to use. I always tell patients, totals your paycheck, freeze what you keep after taxes. So which one do you really care about? Okay. Well, what SARMs do on paper is they suppress the output of sex hormone binding globulin, okay, which theoretically would be a good thing, right?
Mm-hmm.
In theory. I always liken it to this. If you have a river that breaks into 3 creeks and you dam one of the creeks, the other 2 rivers get more. So if I can drop SHBG, I'm clearly going to get more free, okay? And then we'll potentiate androgenic and anabolic effects. The problem is SHBG is a product of the liver almost exclusively. So if I want to significantly influence, that means my mechanism of action has to be at the liver, okay? Yeah. So you're going to give hepatotoxicity, bad for the liver, which what we're going to see is HDL is going to crash. LDL is going to go through the roof, right? So lipid profile is going to be terrible. AST and ALT normally double or triple. We've even seen some weird pancreatic effects with patients where they had goofy things happen with their blood sugar.
Literally, we had a young patient go into having diabetes.
Yeah,
because of SARMs.
He started SARMs totally fine. Did 6 months of SARMs and came in, and all of a sudden his glucose was 405.
Yeah,
wow.
And it's really important, I think, for people to understand. Just because it's over the counter doesn't mean it's safe.
Yeah, and here's the other thing we see is, they do become neuroendocrine suppressive, which means they do shut your natural production down. Now, whether that's because the molecule itself is androgenic enough to trick the brain into shutting off, or it's just because your free abruptly goes from here to here, and that abrupt increase stimulates a neuroendocrine suppressive effect, either way, it shuts it down. So if you were going to say, well, what's the benefit of the SARMs? It would be increasing the percent of testosterone that's bioavailable to the cells, okay? But if your testosterone goes to nothing, an increased percent of nothing is still nothing. Right. So
an increased percent of nothing with bad liver functions.
Exactly.
Worse than nothing.
Yeah. So congratulations, you've tanked your endocrine system at 20, and now you have no testosterone and bad cholesterol, and your hepatic function's a mess. And it's going to take, and again,
it could take years to fix.
To fix that. Yes. In fact, we have a lot of young men that have came in like, dude, I need blood work done. I just feel terrible. Like, what have you been doing? Have you taken anything before? Have you done
nothing.
No,
I haven't taken anything.
Well, I took some Rad 140 and LGD 433 and things like that. I'm like, okay, so you have. And then we explained it. They're like, that's what it does. And they are wrecked. I mean, their endocrine system is wrecked, and
it's fixable, but it takes work.
It's fixable. Yeah. It takes some doing. And again, I'm not, the all out onslaught on hepatic function is not a goal either. In my professional opinion, looking at a bazillion labs of people on not only SARMs, but also like oral anabolic steroids when people have been like, come in taking their own thing and want actually well managed, I would argue that the deleterious effects of SARMs are just as bad, if not worse, than Dianabol or Tranabol or some of these older agents that you see used.
Yeah, I agree.
Mm-hmm.
So.
All right. There are many types of chiropractic. What's best for me?
Yeah, I say that's maybe the bane of chiropractic, because unlike physical therapy or medical doctors, when you go to a chiropractor, you really don't know what you're going to get until you open the door. So as far as what's best for you, my best recommendation would be to definitely go by recommendations, because you can walk into one chiropractor and they won't even touch you, and another one could be slamming on your body with tools. So there's definitely a big thought. I definitely think if I was going to refer someone to a chiropractor, I have a hard time if I don't know the chiropractor personally and what technique they use. Obviously we use what they call full spine technique, which really works on, unlocking joints and getting proper motion back into joints. From what I know, I feel like that's best. I do think there's some validity to upper cervical for certain conditions. I think there's certain situations where chiropractic's not indicated and is overused, when someone has like a disc type injury, getting put on your side and cracked or something like that. Like, find a chiropractor who does diagnostic testing, MRIs, and other stuff. If your chiropractor doesn't have an X-ray unit, doesn't believe in MRIs, it's probably not a safe thing in my opinion. I definitely would recommend going to someone who, I like the idea of working with medical professionals and other providers too. I think we see here at Buckeye, by having Dr. Bain in here and that two-headed approach to things, because chiropractic doesn't fix everything, just like medical doesn't fix everything. So I think the more people you have involved in care and the more diagnostic used, it definitely has a lot to do with it. And chiropractic is very beneficial for a lot of different conditions when applied properly.
With being so health conscious, what do you guys do for fun? That's you too.
Go. You
Uh,
answer it.
I like to eat.
Yeah, what do you guys do for fun?
Like
No,
to
people
read.
ask us this all the
Work
time.
all the time.
Yeah,
yeah,
That's
I know.
literally it.
When you're not working, you
We
like
work
to take a break
7
and
days a
work.
week, 15-hour days. That's what we do,
We're nerds.
actually.
We're
For
actually
fun.
closet nerds. We actually
Um,
like to work out and study and eat good food. Pretty
Yeah,
simple.
I mean, I would probably say what we do for fun. Besides, like, what he says, we like to study, we like to work because we like to help people, but we also love to eat food. But it's really important for us that we do work so hard and we work so many hours that it's at least every quarter we have to go somewhere fun. So we like to travel a lot and we like to go to the beach and to the Caribbean. So that's what we do for fun. We love to travel. And I would say every quarter is a must because we're working 7 days a week.
Where's the next trip?
Aruba.
Hell
Yeah.
yeah. What's a normal day routine look like for you guys?
Well, Buzz gets up before me for sure because he likes to watch the deer eat. So he'll get up. Yeah.
I don't shoot them, by the way.
No.
I usually like to get up in the morning. Your BDNF, which is your brain-derived neurotropic factor, is real high in the morning. So your brain's really high functioning. So I usually get up in the morning, probably like today was 4:30 or 5, and like just read a little bit or just think about what I could get done for the day. Usually have a cup of coffee.
He'll make my coffee for me.
Make your
Aw.
coffee for you.
Yep.
And then usually try to go to the gym around 7 or 7:30
Mhm.
and kind of get that over with, because if I don't go in the morning, I'm not going to go. And that allows me to kind of work the rest of the day.
And I get up and basically
Drink my coffee.
drink my coffee. And then I go to the gym and work out. And then I come home and I work and basically play with the dogs for at least 2 to 3 hours because they are so needy. But he'll be able to work as long as I'm playing with them. So I'm like trying to answer the phone. I'm trying to reply this email, but I got Zuki like crying in my lap with his ball, drooling on my legs. And he's literally whining, or I'll be on the phone with a customer and I'm like, I'm really sorry. My dog is like really whining right now. So I know that you hear him, but he's mad because I'm on the phone and I'll have to like go outside and play with him at the same time. So that's kind of like what it looks like. And then we will shut down around about 7 o'clock
7 o'clock.
and eat dinner. And maybe like last night we were like, let's sit on the couch. And we're like, it's 8 o'clock. Can we just go to bed? We're like, let's just go to bed. And we like to like lay in bed and sit there and talk to each other. That's fun. So yeah,
Aw.
so that's our routine.
Well, Daniela, what's your number one beauty routine must have?
It's funny because when people talk about beauty routines, they're always like, oh, I wash my face, I cleanse my face, I exfoliate my face, I use these creamers and this hydrating spray and yada yada da. My must have are my nails. Okay, I gotta have my nails. Now, these are actually my real nails. They're my real nails. Okay, I know this is a shocker to people, right? People think I get acrylics. No, these are my real nails. But let me tell you, I do get them like dipped so they become hard so that way I don't break them when I lift weights. People will be like, how do you lift weights with those things? It is really hard. I am literally gripping with like the inners of my fingertips. Like, I'm going to get that weight picked up. Wait, can I get this wrap? And I'll be like wrapping my wrist so tight, wrapping it under there. I'm like, I am going to pick it up. So sometimes I have to get them sawed down a little bit. But I would say my nails are a must have for me. And I have a lot of must haves. And when I think of beauty, I think from the scalp down to my feet. And that's how I do it. I care a lot about my scalp. I care a lot about my face. Like must have, like, okay, everybody gets Botox, not a big secret. Like I have a lot of facial expressions, especially when I talk to people. Like if you're talking to me crazy, I'm going to be doing some type of way with my face. I like laser hair removal on the body. I'm like lazy. Whatever I can do to myself that saves me time, I'm doing it. So my beauty routine is how do I save time? And that's eyelashes, hair, nails, everything. But definitely my nails. I can't live without those. And I tried before and like Buzz will be like, scratch my back. And I'm like, don't you remember I cut these off so I could lift weights? And I'll be like scratching his back with nubs. He's like, I can't even feel that. I'm like, well, let me go get my hairbrush. You know what I mean? So these babies are a must have. You will not find me without nails. Have you ever seen me without nails?
Never.
No.
Exactly. And you won't. So.
And on that note, we are done.
Cool.
Cool. So anyways, what a great questionnaire. That was awesome. And thank you for joining us today.
Thanks for having
Thanks
us.
for having us.
Stay tuned. If you have any questions or you want to figure out something to your answer, you have more questions for us or about our lives, we'd love to hear from you. DM us or reach out to us, and we'll be seeing you soon. Thanks.